Thank you. Now that we're all locked in, I know I'm not keeping you from the bar. This has been a very interesting decade in the development of breast surgery, and it has certainly changed enormously in the 10-11 years from 1999 to the present. There's been several themes, of course. Foremost, the increasing subspecialization amongst breast surgeons and the multidisciplinary working with other members of the team, radiology, pathology, etc. The developments in oncoplastic surgery, which I'm not going to discuss this evening, but a lot of work in that field. I am going to discuss changes in the way we stage the axillary nodes in breast cancer. We are an extremely audited group of surgeons with a very rigorous quality assurance program, particularly in the UK, and we all submit or should submit to many national audits that I've shown there. And the conclusion of these changes in breast surgery is that we now offer a very much more patient-tailored treatment to our clients. So I'm going to start with a leading article that, as luck would have it, was published in the very first episode of the BJS in 1999. And it was from a very well-known breast surgeon from the European Cancer Institute in Milan, Veronesi. And he summarized the knowledge about sentinel node biopsy up to that time. So this was really up to 1998. And this was up to a time when most breast surgeons in the UK had not yet adopted this technique. So in that sense, perhaps this leading article was practice changing. Now then, what's happened here? There we are. He made the point that this was a minimally invasive technique that could give accurate information about the state of the axillary lymph nodes before the definitive surgery took place. He championed the use of radio-labeled nanocolloid and an intraoperative handheld probe rather than a pure blue dye technique. But he stressed the importance of very accurate histology in examining the sentinel nodes. Taking one or two sections and examining with H&E was not sufficient. Multiple sections are needed, and he encouraged the use of immunohistochemistry as well. Because micrometastatic disease, as we know now, is very important in determining prognosis and in directing treatment decisions. But we are aware, and we've become aware over this decade, that there are problems with sentinel node biopsy, which will eventually lead me on to my second paper. There are sometimes problems with failure to identify the sentinel node and with false negatives, and many of these instances arise not so much from inexperience on the part of the surgeons, but from nodes being already affected by metastatic disease, leading to the sentinel nodes not actually taking up the colloids. This led to the instigation of several large randomized trials, and in the UK, of course, that was the Almanac trial. And the Almanac trial led on in the UK to probably one of the most important surgical developments, and that was a training program that fully trained consultant surgeons had to go through to demonstrate that they were expert in this technique before they could go ahead in their hospital. And this was probably one of its first of its kind. It didn't happen with laparoscopic cholecystectomy, and we all know it should have done, but it did happen with sentinel node biopsy. What we've come to realize as breast surgeons is that in those patients where the sentinel node proves positive and we have to go back and clear the axilla, we've invented for ourselves a potentially very difficult and challenging operation, much more difficult than doing an axillary clearance straight off. So it would be desirable to try and wean out those patients that were node positive before we got to this stage. There are, of course, two approaches to find out whether the nodes are involved before we operate on them at all, or to find out if they're involved when we're operating on them. So we can look at the topic of pre-operative axillary staging and intra-operative axillary staging. And that leads me to my next paper, which, in the sense answering the question, was it practice changing? The answer is probably no, despite it being, in my opinion, an extremely good paper. And I think the problem was that it was published too soon. This paper also came from 1999, and it was a multi-center trial based mainly in Rotterdam, but from several hospitals in the Netherlands. And of course it was published at a time when the majority of surgeons in the UK had not taken up sentinel node biopsy, and I think its importance was perhaps sadly missed. But looking back, we certainly realize its importance now, because this group were looking at whether you could examine the axilla using ultrasound and use that ultrasound to direct fine needle aspiration biopsy of suspicious lymph nodes and try and pick out the patients who were node positive before they came to surgery. They looked at patients with clinically node-negative axillas. Obviously, if you've got a bunch of pigeons' eggs up in the axilla, you know it's node positive, and you can take a clinical fine needle biopsy of those. But these are patients who are clinically node-negative. They used the best available transducers that they had at that time, but of course we've got better transducers now, and so we're getting better at this technique. And they didn't really have any great expertise in the ultrasound appearances of abnormal lymph nodes, which we've learned a lot more about in the subsequent 10 years. But it was an early and important study. They looked at just 185 patients, typical population of breast cancer patients, median age 54. They found 31 had axillary metastases preoperatively. They were detected by abnormal nodes on ultrasound and a positive FNA. And the remaining 150, and those 31 patients went straight to axillary lymph node clearance, and all 31 were proved to have positive nodes. The remaining 154 had a sentinel node biopsy, and because it was a developmental phase, that was followed by an axillary node dissection as standard. And in 56 of those, they found axillary metastases, but in 8 patients, there were just micrometastases, and 4 were false negative sentinel node biopsies, but they were all very early in the series. So as a result of this very early study, which has certainly led on to our standard approach nowadays, 36% of the node positive patients, or 17% of all the patients, were spared the sentinel node biopsy and could have their definitive procedure straight away. So I think that was a very important paper. And finally, I've chosen a randomized trial as my group of 3 publications that may have changed practice. Now, this was a very important paper because it looked not at the early results of a randomized trial, but the late results. Many of you will have been involved, many of the older members of the audience may have been involved in this original CRC trial, and it seemed to suggest, when the early analysis was done, that tamoxifen was equivalent to surgery and tamoxifen for so-called elderly patients. They chose 70 then as elderly, and of course we know now that that needs revision. It was published in 2004. They're the authors, and I think Tom Bates is somewhere in the audience. And it was a cancer research campaign trial. The patients were recruited in the mid to late 1980s. I think the trial closed in about 1991. But this analysis was done in 1999, and the median follow-up was about 12.7 years. Now, the background of this trial was that the assumption that older women have less aggressive breast cancer and are less tolerant of active therapy. And the hypothesis was that tamoxifen alone might control the tumor over the patient's lifetime and obviate the need for surgery and radiotherapy. 455 patients were randomized, and this was based on their power calculations. And the treatment was 40 milligrams of tamoxifen. I don't think there's any difference between 40 and 20, but that was what was chosen at the time. And the groups were well matched. Now, radiotherapy in this, there was no stipulation that any particular kind of surgery had to be conducted. They could either have a mastectomy or a wide local excision, but they were not allowed to have radiotherapy after wide local excision. The primary endpoint was time to treatment failure, and the analysis was by intention to treat. Now, 57 women randomized to surgery plus tamoxifen progressed versus 141 to tamoxifen alone. Not only that, the time to treatment failure, the median time to treatment failure in the tamoxifen alone group was about 20 months, and it was well over 5 or 6 years or even longer for the surgery and tamoxifen group. And for the patients randomized to surgery plus tamoxifen, the consequences of not giving radiotherapy following breast-conserving surgery resulted in a higher treatment failure. So exactly the same is happening in this older population of women than in younger women as well. And if you analyze before 3 years follow-up, you don't see much difference, but from 3 years onwards, the tamoxifen alone group not only suffered an increased local relapse rate, but a greater mortality, both from all causes and from breast cancer. So the lessons from this important trial were that most relatively fit women in their 70s have a very significant life expectancy, as we now know. And it's important in it's showing that surgery is important. The oncologists don't have all the answers. Good surgery is important in the treatment of cancer, and that's what this trial showed. And the omission of radiotherapy results in poorer local control in older women as well as in younger. Surgery in older women is very well tolerated. There were no deaths from surgery in this trial. And the conclusion is that endocrine therapy alone should be reserved for those with inoperable disease or those who are unfit or unwilling to submit to surgery. So in conclusion, ladies and gentlemen, over this 10-11 year period, there was on average about 1 breast paper of some kind per month in the journal. There were a predominance of good original articles, but some excellent leading articles and reviews. There was a broad coverage of all the relevant topics in the development of breast surgery. There was a good international authorship, other than the United States. And I would advise that breast surgeons should continue to include BJS on their reading list and indeed continue to submit their papers to the journal. Thank you.
Thank you.